Morning, Shauna.
Morning.
How are you?
Good. How are you?
Good.
Mary, there's me.
Oops, I guess I should start my video.
Tara.
Is it says we're recording. Is Haley on? Did she?
Stop.
I don't know.
Huh. Oh, we're recording.
Does it look like she's on? I
Uh,
don't see her on.
I wonder because I wonder if I just put that in my settings. Well, that's good. We want to be recording, so that's good. Good morning, everybody.
Good morning. Good morning.
Good morning.
Seriously. Okay, I don't know if is that me? Do I click on no?
Morning.
Hello.
Hello.
Hey, Shauna.
Yeah.
Cheryl Little's saying she doesn't have the right link today. She's trying to get on.
Okay.
Let me see if I can send it again.
Yeah. I can email it to her if you want to forward me her email address.
I'm sending it to her. I'm sending it to her right now. I think I have her.
Okay.
Short video.
I'm going to pause our recording. I don't feel like we need to be recording. Resume.
Yeah.
Yay. Perfect. Thanks, Shauna. So I know many of you know who I am.
No.
Many of you probably have seen me on different things, but I am by real job, before Hushabye, am a neonatal nurse practitioner. I've worked with babies for over almost 30 years, 28 years, and that's all I've done. So you asked me to do adults, I'm like, I am getting better. I can definitely teach you everything that I have learned in the last few years, which is a lot. I used to believe that you're going to see a lot of this, I guess, throughout the day. I used to think when I had a baby that was born substance exposed that how could this mom do that to this baby? I hope I can change you guys' mind because I didn't understand it. I don't know that I actually said that, but I definitely thought it. And I'm hoping that today I can change, or at least, well, I hope that I can change your thoughts if you guys feel the exact same way. And I've just learned so much from the families that we've been caring for. In about 2015, 2016, my co-founder and I found ourselves working at Banner Baywood, a little 6-bed unit. And at any given time, a few of you worked with me there, we would have 5 or 6 babies withdrawing at a time. And I live in the East Valley, and I was like, what in the world? This is my neighborhood. You know, I figured downtown Phoenix, I figured over by Banner Thunderbird, you would see this. Had no idea that this was occurring in our neighborhood. And so then I started looking at statistics and data and had no idea, again, that we were seeing this in our neonatal intensive care units because I had only worked in what we call the level 3 NICUs, and those are taking care of the sickest of the sick babies. And what I would take care of is I would see them, I would admit them, and then never see them again. Wouldn't even know that they were in our 80 bed unit, which now I'm like, oh my gosh, Tara, that totally was not right. But it just, we just didn't know it. We found out, my co-founder, Kelly, many of you probably know her, is a TV watcher, and she was watching the Today Show, and Lily's Place in West Virginia came up, and they were being interviewed, and they showed that in their tiny little community, I think they have a 30 bed unit, might be 28 bed unit, and at any given time, over 3/4 of the babies in there were babies that were born substance exposed and were going through the withdrawal process. They ended up having to create Lily's Place, where they took the babies out of the NICU, brought them to a specialty center, very much like what Hushabye is going to be. And they take care of babies, and they do fabulous work. It's amazing. We went and visited them, and they made it sound like it was not that difficult to get going. 5 years later, we're here. A little bit difficult, not easy. I do believe that it took this long to get here for a reason. I think that our values, our mission, and we're going to go through that, really needed to change. Initially, Hushabye was all about save the babies. That was it. I don't want to say I didn't care about the moms, but it was definitely save the babies. And when I learned about adverse childhood experiences, I've heard many, many stories from families. Later on this afternoon, you're going to hear from 2 of my mommies that I've worked with very, very closely. It changed my mind. It has changed from save the babies to truly save the families. And that is Hushabye. I know that many of you, your goal or your hope is to snuggle these little ones. I would ask you to snuggle these little ones and embrace the families. That's what I really, that's almost even more important than snuggling the little ones. And I understand that if that's just not your thing, I get it. It's hard. But I will tell you that no one, when they're 4 years old, when someone asks, what do you want to be when you grow up? No one says, I want to be dependent on an opiate or a substance and lose my entire family, lose all of my friends, have nothing be more important to me than that substance. Sometimes different things brought them to where they're at. Many times, from what I find, is it's us in the medical field prescribing them those medications, us not telling them, and I say us because me being a medical provider, us not telling them how addictive these substances can be. So I'm going to share my screen. All of this stuff, sorry, maybe I'm going to share my screen. So just to discuss a little bit, initially our mission was pretty simple to come up with. Like I said, I am a NICU nurse. All of this business side has been so beyond educational and stressful. You're going to hear me say many times, I'm making crap up, because we've been making crap up from the very get-go. But our mission is really to embrace substance exposed babies and their caregivers with compassionate, evidence-based care that changes the course of their entire lives. As we talk today, I think you're really going to see everything that we're doing really encompasses or fulfills this mission statement. I've worked in many different organizations as far as hospital systems, and I kind of was like, mission, whatever. Now I really understand why it's important, and I just hope that you all can jump on board with that. Our vision, I believe, and everyone in our organization believes, that every baby deserves a healthy start. And that will, you all will be able to be part of their healthy and their healthy start and their outcomes as they grow. Our values, we really took a lot into this, trying to figure out what we really wanted to say in as little amount of words as possible, which was not easy. Our values really are innovation. Hushabye is, it's not done anywhere in the United States. Lily's Place and Bridget's Path do babies. They do the baby portion. The mommy portion is not done. And we're going to talk a little bit more about what else Hushabye does when I'm talking mommy and daddy portion. Nurturing families with integrity and showing them respect and compassion. What does that mean? The client's right. We sometimes just need to educate and help them get to the point that they understand where we're coming from, but really not being judgy at all. Empowering ourselves and those that we serve through education. So all of you that are on here today, us helping educate you what we have learned, and anything that I am saying is not meant to be, to come across wrong, I guess. I didn't know most of this 5 years ago. Most of this I have learned, and should I have known it when I went to nursing school and everything? I should have. A lot of what we're going to learn throughout the day still is not being taught in medical school or nursing school. It should be, but it's not. So really, a lot of the information that you're going to hear today is kind of, I want to say sacred learning, but it's really, you're ahead of the game, ahead of the community. And then lastly, promoting the health of the whole person, their physical, their mental, and their emotional health. And that not just being baby, but that also being the entire family system, as well as all of you. We know that if we're not healthy as caregivers, how are we able to really provide the best care for our little ones? When you all are able to visit us next week on site, I hope that you will feel the environment that we really wanted to bring to it. And what that environment is I want us to be able to walk into Hushabye Nursery, and you should immediately just be like, oh, I've got this. That also is what I want for our families. I want them to come in and know that they're not going to get judged, that we are there for them, and we're going to meet them where they're at. And some may roll their eyes to this. If that means mom and dad just used in the parking lot and they walk through the doors, it's still us being respectful and being there, hoping that maybe that 30 seconds ago that they used previously is the last time that they ever use again. You never know the point in time that someone can make an impact in someone's recovery. And you'll hear that from other moms and dads when you're talking. And it's quite an impressive, I don't know, quite a gift that you can give someone, but amazing when you all obviously that are on this call want to give back. And I don't know how much more you can give back than being that part of someone's life in the recovery. And then also caring for their baby the way that you would want your little one cared for. So today, this afternoon, for the next hour, what I'm going to talk about is neonatal abstinence syndrome and/or neonatal opioid withdrawal syndrome. We're going to talk about that. What causes it, the signs and symptoms, and then the treatment. I'm hoping you guys can see this and hear this. A crying baby is always unsettling.
Yep, you're good, Tara. We can see everything. Should we be able to hear it? I can't hear it. Can you guys hear it?
No, not really. I just heard a faint baby crying.
Okay. Maybe I'll send this video to you guys. But you could see baby moving, right? And wiggling.
Jittery. Mhm.
Jittery. Okay, perfect. But I'll send the video to you all. More or
Tara-
less.
Tara,
Yeah.
if you want, you can send me the link in the chat box and I can try to do it for mine if you want to later.
Yeah, for sure. For sure. So this little one that's withdrawing, just so you all kind of are prepared, that is kind of just like a little bit of withdrawal. That's not a lot of withdrawal. So many of us want to just love and snuggle on these little ones. It's hard. It's hard work. It's not just, oh, let me just let them snuggle and do this. We'll get you there. We'll teach you how to do this. The nurses, the nurse practitioners, Shauna and all of them, we will get you to the point of knowing how to snuggle with these little ones. I know Stuart and a few of you have said that you've worked with these little ones in the past. I'm sure that you can teach us stuff. But every baby is completely different. And it really does take a whole bunch of us to figure out what these little ones need. I will guarantee you that if we can teach a family member, biological family member, how to care for their baby the way we know, their baby's going to respond better than to us. Right now in Arizona, 2 babies are born passively dependent every day. When I say passively dependent, that was probably one of the first things that I was taught. I was asked to speak at a conference, and someone in the audience, this was 4 years ago, said, you know, they're not drug addicted. And I'm like, and I learned a lot, because no baby asked to be born dependent on substances. So you're not going to hear us throughout the day talk about really addiction. We'll talk addiction, but addicted so much, druggies, junkies. I got to think of all of the kind of the negative connotations, negative words. We're going to use opiate use disorder, and that's what I would hope all of you will adopt. What that means is someone dependent on opiates, or those other words that we used to use. You're going to hear us say substance use disorder, and that's being dependent on other substances along with opiates. We're going to talk over and over and over again about that, because one of the biggest things that families talk about is being judged, and the stigma that goes along with their opiate use disorder or substance use disorder is a biggie. This graphic here, I think the biggest thing that hits me is 4 out of 5 new heroin users start by misusing prescription painkillers. There's studies that show if you take pain pills for greater than 3 days, there's like increases your likelihood of becoming dependent on opiates by 10-fold. If you use them longer than 10 days straight, so say you have knee surgery, your doctor gives you pain meds and use them for 10 days straight, you're likely to become dependent on those opiates. I think it's 20-fold. Hence, the legislation that went into effect 2 years ago, I believe, that a prescription for pain pills can only be written for 10 days is from that data. So I know many people are so upset that legislation passed. They felt that, you know, I'm not, I don't have an issue. It's not me, it's those people. And they felt like they were being punished. There's data behind it. That's why it went through. Again, I didn't know about that data. I had no idea. The other biggie in this graphic is 4 out of 10 of us have someone very close to us dependent on opiates. I think we're getting better at talking about it, not being so shut in and being embarrassed about it, because people are understanding and getting better at learning that really opiate use disorder, substance use disorder, that's their diagnosis that we give them in the hospital by the physicians, is a brain disease. It's a chronic illness. Those substances actually change the development of the brain and how it works. We're going to talk about that more later on. So what is neonatal abstinence syndrome? It's a baby that is exposed prenatally to a mama that has been taking medications or substances other than, so they could be taking opiates, but also cocaine, methamphetamine, all of those, everything together causes neonatal abstinence syndrome. When baby's born, you clip the umbilical cord, baby's not getting exposed to those substances in there anymore, and they're going to go through that withdrawal period, just like an adult would. Neonatal opioid withdrawal syndrome, or NAS, that's what everybody's trying to get to. I'm still not there, so you're going to hear me almost always talk about NAS. And the reason I say that is because very few people that are dependent on opiates are only dependent on that substance. If they are taking anything illegal off the street, almost everything is laced with something else. So you have people that are thinking that they're taking only Percocets, they're off the street. They probably have methamphetamine in them, cocaine, fentanyl. They just don't know. So neonatal opioid withdrawal syndrome is only being exposed to opiates. NAS is being exposed to all different substances along with an opiate. Again, when the umbilical cord is clamped, they're not getting the substance anymore, and they start showing evidence of withdrawal. Other causes of NAS that could cause things: your street drugs, your prescription pain meds, herbal remedies. I don't know if any of you have heard about kratom. Kratom is still, now people will be like, okay, I'm going to go to a smoke shop. But kratom is still available over the counter at smoke shops. What it is it's an herb that is an opiate. You're seeing more and more of it. Many people will drink it as a tea, and they don't know that it's an opiate. They just know that the kratom tea makes them feel better. And if they have their kratom tea, they immediately feel better. And they'll be like, I get an upset stomach, I don't feel good, I have a headache, but as soon as I drink my tea, I'm better. It's an opiate and it's becoming a problem. It's still legal. They've taken it off different shelves. Many of you have probably seen at Circle K's or any of the convenience stores, there used to be packages of like 4 or 5 vitamins is what it looked like. And one of those was kratom. And it would say quick recovery, quick energy. And one was kratom. And so it hooked people. Yeah, it made you feel better, made you feel really a lot better. Alcohol, you can see, cause some withdrawal. Cigarettes, definitely, and caffeine. Caffeine, we all kind of go, really? If you're a really heavy caffeinator, I don't know, whatever you want to call it, yeah, your baby probably gets a little irritable. But definitely that cigarette, we see that a lot. Substances that really, truly cause NAS, your prescription pain meds, your morphine, your methadone, Suboxone, Subutex, all of those on the left side. And then your street drugs, your heroin, oxys, and fentanyl. And then you have non-opiates, which are your SSRIs and your benzodiazepines. Those two on the bottom, those two types of medications, they withdraw like at 2 weeks. from those substances. Many times, if they're exposed to those medications, they are not in the hospital anymore. We don't know that they're having a hard time. Now, if babies are having a hard time from their opiate exposure, these little ones, if you look at it, look back, they might start having a really hard time at day 14, maybe, 10 to 21. But we may think, oh my gosh, they're doing so well. And then all of a sudden they're not. And then if you look back at mom's history, if she's forthcoming with it, we may realize that, oh, it actually is another exposure to another substance. Very rarely could I say that we really put 2 and 2 together. We just know that the baby's not doing well. Substances that may cause NAS, but not guaranteed: cocaine, crack, methamphetamine, speed, and ecstasy. I have never, ever seen a crack baby, like what we call it. I have had many babies exposed to cocaine or crack. I've not seen them withdraw. I've just not seen it. I don't know why. I don't know, in the 80s when you would see commercials, showing babies that were withdrawing and saying they're crack babies. I've never seen it. The way we talk, you guys, really makes a difference. And again, that's all day today, all day tomorrow. We're going to talk about this. Meth. Very common. People will come to me and say, mom's on meth. I'm like, okay, methamphetamine or methadone? Methamphetamine, babies aren't going to withdraw from. They're not. It could make withdrawal a little bit harder if they're exposed to an opiate also, but it's not like we're going to go, oh gosh, they're gonna withdraw. Not necessarily. Methadone is the only proven effective treatment for someone with opiate use disorder, someone dependent on an opiate. But are babies going to withdraw from it? Absolutely. And you're going to see many of our little ones be exposed to nothing but the medication that they are prescribed and that they are taking to be healthy, functioning, parenting adults. So we're going to talk more and more. So when someone says baby's exposed to meth, I always have to go methamphetamine, because it's like, darn it, they're not in recovery. Or methadone means mom's in recovery, or really working hard to be in recovery. So it's a good thing. Methamphetamine, not a good thing. Questions on any of that before I keep going?
The chat box is clear unless somebody has something they want to
Okay.
ask out loud.
We'll keep going, but you guys just go ahead and interrupt me if you need to. NAS withdrawal symptoms, what do we see? I had one mom explain to me withdrawal was like having the worst flu and migraine times 100. When she dumbed it down for me like that, I was like, oh my gosh, that's exactly what we see in a baby. So vomiting, diarrhea, you're sweating, you have the chills, you're very achy, you have a stuffy nose, you sneeze, you just can't sleep, you're miserable. The things that we see additional to babies, and sometimes when you have the flu, you'll get shaky, but you will definitely see those tremors, that jitteriness. You're going to see them initially be able to eat pretty well, and then that sucking and that feeding is going to become what we call very discoordinated. They will not be able to figure out how to suck, swallow, and breathe in sync. And I'm one of those that cannot eat and talk at the same time. And so that's very much that coordination of being able to suck, swallow, and breathe is really, we kind of take that for granted. But these little ones initially will do really well, and then they have a hard time. You'll see them need that pacifier no matter what. Every one of our babies at Hushabye gets a pacifier. I don't care. And if a family does not want them to have a pacifier, we need to teach that baby how to suck their thumb. And we'll get there. Babies need to be able to suck. Sucking releases endorphins. Endorphins make them feel better. I haven't had a mom, when I explain that, not give her baby a pacifier. Now, some babies can't figure out a pacifier. That's different. You'll see babies breathe really, really fast. And the one thing that we are trying to avoid at all costs is seizures. They will be very stuffy nasally. They'll sneeze a lot. Modeling of the skin, we're going to talk about that. Here's the modeling of the skin. This can be a very normal finding in any baby that is stressed. It's a stress signal. You see it very commonly with these little ones. They may be doing everything great, but you'll see this lacy appearance all over their body, sometimes just on their limbs. But when you see it, just know that maybe they're doing good, maybe they're sucking on their pacifier, but boy, they're still saying that this is still kind of hard work. You'll see excoriation to the face and the limbs. See here on the chin, usually what that is caused from is we have them wrapped and they're frantic. And as they're frantic, they rub their chin raw. Very, very common. Babies having the worst diaper rash that you could ever imagine is very common with these little ones. As you guys hear us teach, the nurses, Shauna, one of the biggies that I teach families is frost your baby's butt. Every diaper change, something goes on it, and not just like a little bit of Desitin or a little bit of Aquaphor. I want it coated. So frost their booty like a cake. That's what I want. Because if we can diaper change, yes.
So sorry, is there any way you can turn your volume up just a little? Mary's saying that she's having a hard time hearing. Or are you all the way up?
Just one second. Let me see. Whoops. Ooh. Okay, just a sec. I'm gonna do this first. Maybe. My pointer's now not working. Here. We're gonna stop share. Sorry, you guys. Okay. Now I'm up to 100.
Okay. Mary, is that better?
Can you hear me now? Can you hear me now?
You're muted, Mary.
Is it better?
Is it better? Yeah.
A little bit, yes.
Okay.
Okay.
Sorry, you guys. I have it. That's as loud as it goes. Let me go back. Okay, so excoriation, we were talking about that. I have even had a baby. I had a couple babies in a row that had, it looked like the one little baby, Tech, you and I took care of this little one together, looked like mom or grandma had trimmed the nails down too far. And it was interesting because the grandma was very concerned about the nails. And we were like, we don't cut them, we just file them. Otherwise you can kind of like peel them off because they're not hard when they're babies. And the little one had scabs on every fingernail, every one of them. And we were like, oh my gosh, okay, well, let's be careful with that. And I think I had 3 babies in a row, like very quickly, week after week, that had the same thing on their toes and on their fingernails. And we figured it out. Well, we think we figured it out that they were so shaky in their blanket that they actually were making them raw. And it was like, oh, okay. I had never seen that. So sometimes you will see that there. Hypertonicity or increased tone. What that means is like you're not able to bring them down. That's not uncommon. Really changing their diaper sometimes is really hard to pull those legs down to get their diaper changed. Getting their hands away from their face can be hard. But just so you know, you always want their hands to their face. Sucking and hands to their face are good things. Every baby, almost every baby that you see in an ultrasound has their hands to their face or above their head. That's just comforting for them. You'll see some nurses and any nurses that are on here that still wrap with your hands to your sides. They change it because Hushabye's wrapping with their hands to their face. That is developmentally appropriate. Even if anybody's rolling their eyes right now, that's what we're doing at Hushabye. I get to make that rule. So, assessment tools. What do we look at? So we're looking at all of those signs and symptoms that we talked about, plus a whole bunch more. And there's two different types of assessment tools. There's what we call modified Finnegan, which is very detailed. It's 21 things that you look at, and you give a baby a score after adding it up. It is not a very, what am I trying to say? I can't think, valid tool. It's the only tool that we used up until probably 2 years ago, and it's very subjective. And so getting me to do it and Shauna to do it and to get the same score at the same time was very rare. I believe that if we're all trained on it the same way, I think that we can get that score to be valid. So at Hushabye, we're going to do that tool, but we're also going to do the Eat, Sleep, and Console. And we're going to go through Eat, Sleep, and Console specifically here in a little bit. But the modified Finnegan, just so you can see, the nurses, I know all of you nurses have seen this, but volunteers, just so you can see what we're doing and why it's just long. I know this is small, but we'll have it printed out. But what you're looking for is if a baby has a high-pitched cry. If they do, you give them a score of 2. If you cannot get them to stop crying for greater than 5 minutes, then they get a score of 3. You look at how they're eating, how long they're able to sleep. You look at that excoriation. You look at all of these different signs and symptoms of withdrawal, and you add them up and you give them a score. If that score is greater than 8, it's concerning. And it kind of tells us like, ooh, they're having a hard time. Now, my hope with Hushabye is that we're all doing it the same way. So we can say that that score of 8 is probably pretty correct. What happens right now in the hospital is I could have a nurse say this baby scored a 16, which is extremely high. I get baby and I assess baby. I get them calm. I do all my magic, and they end up scoring a, say, 5. And it's like, okay, what is that discrepancy from a 16 to a 5? A lot of it is the fact that we're just not educated the same. A lot of it is this is not our population, and we do not want to care for these babies. I can guarantee you that when I was early on in my nursing career with Cheryl, if I had a baby that was substance exposed and going through withdrawal, I made sure the next shift that I was on, I got there early so I could say that I wasn't taking that baby. Mean, awful, true. These little ones are hard to care for. They're very demanding. And when you're in the hospital in the NICU and you have 2 other babies on your assignment, so you have 3 babies, sometimes even 2 or 3 babies that are all withdrawing at a time, it's impossible to care for them. When you have 3 scores of 8 or greater, 3 scores that equal 24 or more, used to be that we would automatically start them on pharmacologic therapy. Right now at Hushabye, we're going to all huddle together. We're all going to talk, and we're going to all evaluate along with the family or the caregiver for that baby to figure out what we need to do. So Eat, Sleep, and Console is much easier. You look at 3 things. That's it. You don't look at those 21. You look at, can a baby eat an ounce? Whoops. I'll go back to it. But can they eat an ounce? Can they sleep for an hour? And can they be consoled within 10 minutes? And if they can't be consoled within 10 minutes by me, then I give them to Brooke. And if Brooke can't console them within 20 minutes, we all huddle together and figure out what we do. What that Eat, Sleep, and Console model has shown that it's been able to decrease the length of stay, and it's decreased our need to give a baby an opiate to withdraw. So Hushabye, what our plan is, we're going to go to Eat, Sleep, Console here in a little bit further, but what we're doing here at Hushabye, at Hushabye, I guess that's what I want to say. The very first thing that I challenge every one of you to do. The very first thing every mom that and dad that you meet is congratulations. I don't care if they used in the parking lot and they come in. Congratulations. I'm so excited for you. Your baby's beautiful. Babies are supposed to be fun. Yeah, this isn't the perfect environment, but what if you can be that one person that made a difference? What if you are the, tech, you talk to a mom and she just says, she was just so nice. She made it sound like, I could do it. She gave me a little hope. What if you are that person? Congratulations. Someone taught me that. And I will tell you, I do it with every mom that I am connected with. Absolutely every time. I never, ever forget it. Congratulations. I'm so excited for you. Your baby's beautiful. Because as soon as you do that, you bring down the walls and you start building trust with that family. We connect them prenatally with obstetricians or their high risk doctor. We would like to eventually offer birthing classes. I have had, or Hushabye has had 109 babies born in our program prenatally since February of 2019. 2 families out of the 109 have done birthing classes. 1 family did a birthing class and said she wished she wouldn't have because of the judginess, because of, they were just very uncomfortable. So our hope would be eventually to do those Lamaze classes or whatever you want to call those birthing classes on site at Hushabye. We educate the families on THC. Many families, many people don't think pot's a biggie. Studies are coming out of Seattle and out of Colorado that pot is a biggie. I tell my moms that, THC is a big deal. We don't want you doing it, but I will also tell them if it's between THC and heroin, okay, smoke all the pot you want because I want you around. But it is a biggie. It's not just as, I don't know, whatever, safe as what everyone thinks. We educate them that Department of Child Safety is going to get involved no matter what. Even if you've been in recovery on methadone and stable for years, DCS is going to come in and meet with you and talk with you to make sure that everything's okay. And that's all right. Department of Child Safety, their name, child safety, their goal, number 1, baby being safe. And believe it or not, their number 2 goal is keeping families unified. Hushabye's number 1 goal is healthy mom, 2, healthy baby, 3, safe baby, and 4, keeping families together. So really safe and keeping families unified, we have the exact same missions. And so really explaining to these families that Department of Child Safety is here, they are scary. I can't imagine them being involved with my kids, but really it should be a collaborative approach and not a punitive approach. Substance Exposed Newborn Safe Environment Program, that is a DCS program, but what they do is they bring in counselors, they bring in the family, they have substance training or counseling services, Head Start or home visiting is involved in that program. What they found is if you have all of these people involved in a family's life, that by golly, those families are successful. No brainer. We know that if people have support, you're successful. And that's what Hushabye is about. We help them identify safety monitors. What a safety monitor is say, I'm not in recovery and I'm having a really hard time and I'm having a baby and I go into the hospital and I used 30 seconds before I delivered. And Shauna is my sister, and Shauna is very healthy and doing great. And she knows that I've been struggling, but Shauna says, I will take Tara's baby and Tara can still come to my home when she's healthy. Not meaning that I have to be healthy for days, but meaning that I'm not under the influence at that time and I'm safe and I can still parent my baby while I'm trying to get through the recovery process. And so that is a safety monitor. Families, if they don't know prenatally who a safety monitor could be, I have had instances that there were safety monitors, but they didn't know when DCS came in what they were really asking about. And so really helping them identify that. We teach them what the withdrawal signs and symptoms look like, and I'm going to teach you what interventions you can do. We educate them that, by golly, we want you to breastfeed. If you are I have to get rid of that word. If you are taking only prescribed methadone or buprenorphine, Subutex, Suboxone, that's the other name for it, you are absolutely and recommended, it is safe for you to breastfeed. So that's hard, you guys, when you're probably like, oh my gosh, you're going to let them breastfeed. Studies show they do better. And many of you are like, well, duh, they do better because they're getting the methadone, the opiate through the breast milk to the baby. And yeah, they're going to do better. Actually, they've done those studies and it's less than 1% of whatever mom's dose is goes through the breast milk. We believe it's the bonding. Taste is much better. It's much easier to digest. In the hospital, we have babies that are this big and we pay, I think, $5 an ounce of donor breast milk because we know that breast milk is best and it's the most gentle on their tummies. Babies that are substance exposed have not good tummies, vomiting and diarrhea. It actually, the opiate is shown to ruin like the lining of the gut. And I'm not going to go into that. But breastfeeding, we believe that's why it's better. You hear breast is best, and I'm not going to say everybody needs to breastfeed, but if a mom wants to, we need to encourage that and we need to help that. I know we have one of the nurses that is on our team that is a lactation consultant. So we will have that support. Many of us have been doing this for years, and so we can help them. We also make sure prenatally that these families have been tested for HIV and hepatitis C. Management of NAS. We're going to go through that, but I'm going to let everybody take like a 5-minute break and we can go through this. Is that okay?
Sure.
Okay. So why don't we 10:15 come back on and we'll go through more. And any questions?
Can you say what the SENSE stood for again?
Yeah, it's substance exposed newborn safe environment.
Thank you.
Mm-hmm. And that would be one of those programs that when we have a baby that goes into foster care or when a baby DCS is really going to be involved, that we need to kind of be an advocate for families to ask for this program. Not everybody gets offered it. Many times they get offered it and people are like, heck no, I'm not going to do that program. I don't want DCS in my life. They need to do the program. When DCS says things are voluntary, just so you all know, it's not really voluntary. It's kind of voluntold. And if you deny services, that does not look good. So they will say they're voluntary services, but if you want your baby returned to you, you'll do the services. And a lot of times our families don't hear that. I wouldn't hear it. When I've heard DCS people explain it, I'm like, well, you said it was voluntary. And they're like, well, I can't make them do it. And I'm like, I know, but you said it was voluntary, which I think voluntary means, I get a choice if I want to do it and it doesn't make a difference that I wouldn't give my baby back. Anything that DCS recommends they need to do. And so you all will be big components of helping explain that to these families when they're involved. Sorry, I'm reading. No, that was Cheryl. Yeah, and did I used to say that babies were drug addicted all the time? On one of my very first videos that I just recently Googled myself to see like what came up. I'm like, somebody said something. I'm like, I better Google myself and see what comes up. In my very first interview, we called babies addicted. I think we even said addicts. I was like, oh my God, that's so wrong. What did I do? So it's not just you, Cheryl. And you're also going to hear, DCS is going to say it. People are going to say it. A lot of people are going to say it. And so babies that are exposed, babies that are born dependent on the substances that their moms were taking. Do I expect this language to just come easy? No, it's hard. You heard me say what, I don't know what I said, used, or I don't know. I used a word in there that at times I'm like, oh, that wasn't right. And I know that Julie and Shauna are really, really good at trauma-informed care and at helping us understand that our words and how we say it are a biggie. You will hear families call themselves addicts. I always correct them and tell them you have opiate use disorder. It's a chronic illness. It's a brain disease. I go through that over and over and over with them. They will still say, once an addict, always an addict. And I'm like, yeah, no, you have opiate use disorder. It's a chronic illness and you'll always have it. Angie, breastfeeding with THC card. You can do it. You can. I mean, it's legal. I will tell you, many of our families, when I explain to them that it does go through, my families that I've worked with, they opt not to breastfeed. They do. I just think we have to give them the education on it. Just because it's legal doesn't mean that it's always safe.
Tara, sorry, real quick. I don't think that her question showed up in the chat. I'm sorry, what was the question, Angie?
Oh, sorry. I think I sent it just to Tara. Previously in the NICUs, we've had moms with a THC card that want to breastfeed. And even like some medications for anything, for blood pressure, you know, like Tara said, just because it's legal to be prescribed and to be on it doesn't always mean it's great to breastfeed with it. But I wondered where we were with THC.
Yeah. With that, if it's a medical card, yes, I will tell you that prescribed Percocets, Vicodins, those things. So you'll have moms that don't have, they think they don't have opiate use disorder because they just take legal drugs,
Right.
legal prescriptions. They cannot breastfeed at Hushabye. That has not been studied. The amount of that Percocet going through the baby to the breast milk to the baby. Methadone and buprenorphine have been studied galore, and it has been proven safe. But Percocets and Vicodins, we're going to have that discussion with those families. Those babies are still going to withdraw. And shame on the obstetrician or the provider that didn't get those families transitioned to methadone or buprenorphine during pregnancy, because that is a recommendation by the American College of Obstetrics and Gynecology. So if you have, a mom that has chronic back pain and she's on Vicodin, right now, the recommendation is that mommy gets transitioned over to methadone or buprenorphine during pregnancy. So they should have done that. I did have one obstetrician not happy with me because had a mom that wanted to breastfeed, and I said, I can't do it. And I will tell you just a little bit background on that. I had a mom that was taking Vicodin. This was probably 15 years ago, and a lot of Vicodin. She had, I think, 8 children. This was her 9th. This baby was preemie. And every time this mommy, every time she had a new nurse, she was like, I want to breastfeed. And she'd get baby right there. And I would have to come and talk to her and say, it's not proven safe. We're worried about this, blah, 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 blah. She took that little one home, and that baby came back dead on arrival. And she didn't know if she breastfed. And they did a toxicology, and the baby had overdosed. So I have learned once, and I'm not doing that. Yeah. There's nothing evidence-based that shows that that it is safe. And so, in our mission statement that it says evidence-based practice, that's what we're going by. If they can find something and they can show me a few research studies, sure. We had a mommy recently that was on taking 240 milligrams of methadone a day. And we're going to talk more about this. I don't really care about the dose, but the medical provider at the hospital did not feel comfortable giving this baby her breast milk. And I looked for data. Her baby was a preemie. I could find one study, that addressed a preemie baby taking being exposed to a dose of greater than 200. They said that it was safe, but it was one study with one baby. And so what we talked through the medical team was give half breast milk. So we said baby's getting 120 milligrams of being exposed to 120 milligrams of methadone. And then they gave half formula. It was kind of a good, just working together and going, mom really wanted to breastfeed. We knew it was best for baby. But we also needed to be safe. And believe me, I looked through data, trying to find something that said it was safe for a preemie baby and found one. So we compromised on that. Okay, so let's give 5 minutes. So go to the restroom and then we'll talk really quick.
And in the meantime, if you guys have questions, go ahead and stick them in the chat box and we'll make sure we get all those answered.
Perfect. Management of NAS or NAS. Non-pharmacologic is their parents, number one. I can't stress that enough. If we can have them there, babies do better with their moms. Turning down the lights, making it a quiet, dark environment, having our phones on vibrate or mute, teaching the families how to do skin to skin. And what that means is putting baby right on your chest, putting them inside your shirt and doing that skin to skin with mom or dad. Rooming in or nesting, and we're doing that at Hushabye. Every baby will have a private room where mom and dad can stay 24/7. There's a captain's bed in every room. We can roll in a cot if we need to for if dad's going to stay 24/7 or if they're going to switch on and off, where they can definitely be there. Breastfeeding, infant massage, we'll do some teaching with that. We have a couple nurses that are also trained in infant massage. And then just like you and I, when you have a tummy ache, I heat one of those beanbag packs in the microwave and then put it on my tummy. We can put little warm compresses or a washcloth that's been put in the dryer. We can put that on their tummy and it can help. Many of the nurses will probably be like, I did this. Many of you that have had kids, if you had a colicky baby, you probably will come up with something and be like, did you ever try this? That will work. You never know what's going to work at a certain time with these little ones. We teach families to turn down the lights. We try to limit the visitors. We'll go through that visiting policy. I think everything else, the one thing that I did not go through is rubbing and stroking. So, when we have babies, any baby, the first thing you do is you're like, oh, look at how pretty they are. And you just touch their face and you go like this. And it's like, oh, they're so pretty. Think of when you have the flu and somebody comes up and does that to you. You're like, oh my gosh, leave me alone. That's exactly like what our little ones feel like, or I think they feel like. So when you're holding them, putting pressure on their head, their butt, and just doing that pressure instead of that rubbing, it really just seems like babies, you'll just see them kind of twinge, like, leave me alone. But, we're just like, oh, okay, they're kind of ticklish. That just isn't great. They don't like it. Smoking can really be an irritant to these little ones. There truly is, secondhand smoke, but third-hand smoke is a biggie. And we can have those conversations with those families that are heavy smokers about washing your hands after you smoke. We can offer them shirts to change into so that when they come back in, if they are one of those heavy smokers, that it doesn't bug their baby. Deep breathing. So you and I, when you take in a deep breath, and then you hold it, and then you let it out. Relaxes you. I mean, I just did that and it's like, oh, okay, I should do that more. If we can teach these families how to do those deep yoga breaths, their babies respond. I will tell you, I did it with my kids when they were just fussy, holding them here. And I would just I didn't know what I was doing. I just knew that taking a deep breath helped them. But if you do that, sometimes these babies are panting and they're just breathing fast. And you do a deep breath and you hold it, you'll all of a sudden be like, okay, now they're settling down. Again, if we can teach families how to do that, it really, really works. Positioning them, swaddling them with their hands to their face, their knees to their chest. I'm going to show you a video, or Shauna's going to try showing it, and then swaddling them. Everyone, again, swaddles babies differently. All the nurses, you guys that are on, if you're, again, I'm going to stress, if you're a swaddler that puts their hands down, no, hands to their face. We have the snooze, which are fancy schmancy, like beyond expensive bassinets at Hushabye. When you're watching the video, they put the hands down. You're putting the hands to the face. That's developmentally appropriate. I know a few of you are developmental specialists. You will agree with me, and we've all been taught it. Hands to their face. Now, if they're scratching their face, we can put things over it, or you can wrap them so that they can't get out if they're scratching their face, but they should be able to be in this position. That's comforting. Even if it's under a blanket, they should be able to be like this. The squat, I'm going to show you a video on that. Sometimes babies, the last one, sometimes babies, when you have your grandbaby or your own baby, we always look at them face to face because it's like, oh, you want to interact, you want to cool and caw, and that's just what you do. Babies that are substance exposed are hyper alert. And so getting in their face and doing this face to face is too much for them. They can't even breathe and be in their skin and try to interact with you. So sometimes, you know, when you're feeding them, you're looking at their eyes and they're trying to eat and they're trying to engage in you, but they're trying to suck, swallow, and breathe. Sometimes it's too much. So when you're looking at them, and we're going to teach many of you this, try not to look them in their eyes, which seems really not normal or appropriate. But with a baby that's substance exposed, it is appropriate. And so when you're feeding them, you can look at their head, their nose, their mouth, but not eye to eye. Now, sometimes babies at the 8 a.m. feeding might be able to just be able to interact with you, Mom or Mary. And it's just like, oh, look, this is a good time. But at the 11 o'clock feeding, when they're going to eat, Mary feeds them. And it's like, oh my gosh, I can't even look at them. Otherwise they cough and sputter and they just can't get it together. We're going to teach you all of that. And every baby is going to teach us something. So non-pharmacological techniques, swaddling your baby, doing a side or stomach carrying, kind of laying them on their tummy, suckling, pacifier, no matter what. The swing, we'll have swings that we can put the babies in. You guys rocking them can definitely do it. That video is going to talk about the shush. The stay calm is that deep breathing. And then the squat, the video is going to go through. Shauna, do you want to see if you can do that video and see if it works on yours? You're muted. This video, you guys, is on our webpage if you want to ever use it or give it to a family so when they're going home that they can watch it.
Yes, this is on the right-hand side on the very bottom. So we're going to watch how to comfort your baby. So let me know if you can't hear it, because then something is wrong.
The withdrawal is really hard. There's a few things that can make withdrawal just a little bit easier. Number one, their parents, biological, mom and dad being present. That's what you want. Number two, babies being able to breastfeed. So if it is not contraindicated, really, babies need to breastfeed, and we need to encourage these mamas to do so. The other things that we can do that can make it just a little bit easier, I'm going to show. So usually with a baby, a regular baby that's not having trouble with withdrawal, we hold them face to face, we bounce them, we do this pat, pat, pat. Remember that these little ones are really hypersensitive. So turning down the lights, shutting off the TV, and the computer, wrapping them very tightly. Remember, these little ones have tummy aches. Withdrawal, one of the main symptoms of withdrawal is GI upset. So when you wrap them, you need to make them very tight. We're gonna act like this is a baseball field. You have first, second, third base. You wrap down second base to the pitcher's mound. You're going to position the baby about an inch below that. Make sure you put your hands to your face, take first base all the way around and wrap it up behind their booty. Knees to their chest because they have tummy aches. Take home plate and put it up and over that shoulder. Take third base and wrap it around for that home run. So you have them bundled like a little burrito. Now, sometimes this face-to-face movement is too much for these little ones. That's hypersensitive.
Just lost video, Shauna, I think, because you put yourself on mute. Or not video, noise.
Changed them, you know that that is not the answer. You've wrapped them, bundled them. More than likely they have a tummy ache and they're just experiencing horrible withdrawals. All of these little ones, no matter what, get a pacifier. So when you have that family that says, no, we don't want to have a pacifier, the only way babies can self-soothe, hands to their face and sucking. We have to let them have that opportunity. So sometimes turning them away from you, you've turned down the lights, you've shut off all the electronics, holding their knees to their chest, they're gonna kick away from you because they have that tummy ache. First thing that a baby does is they go straight. You're gonna hold their knees to their chest and they're gonna push. And you're gonna start doing what we call the squat, up and down motion. And when you're doing that, then you're going to do the shh, 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 shh. What that shush is that's mimicking mom's heartbeat. As you're getting tired with your legs, because you are doing that squat, go up on your heels and continue that. Now, as you've done that, remember you've changed their diaper, they've been fed. Usually when you do the squat, they're gonna give you that great big burp that they haven't been able to do because they finally have relaxed enough. As you get tired, if you can realize that truly you're starting to get anxious. So just pause for a second, take that deep yoga breath, and I want you to do 3 of them. So, and hold it in and let go. Since I've been doing this, I haven't had one baby that doesn't stop and like look at me like, what in the world did you just do? By the time that I've done 3 of those deep yoga breaths, I've not only decompressed my anxiety, I've interrupted their fit 3 times. Then you go back to holding the pacifier in their mouth, you're holding their knees to their chest, you're holding them tightly, and you're going up and down. Shh, 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 shh. Remember, all stimuli, as much as you can, you need to decrease. Usually, these things work. Teaching families how to do these are even more effective.
Thank you, Shauna. Okay, so many of you are probably like, okay, my knees won't do that. There's no way in the world that I can do that. We can do it with the rocking. It may be one of those that I have to go, yeah, I can't do it, Anita, you need to do it. I mean, it truly is a team effort, you know, having the mom do it. Mom's exhausted, then I do it. We just take turns. And I will tell you, I mean, I've had that many times that nurses are like, I can, you know, say Angie brings me a baby and it's like, they're impossible. And I'm like, just let me try. Just give me a minute. And I literally would take them in the closet in the hospital, turn down all of the lights completely black and do that deep breathing, get them tight, hold them away from me and go up and down. And I would get them settled. And it was like, okay, sometimes it works. A lot of times it works taking them from their mommies and daddies because they feel so awful. They know how it feels to withdraw, and they are devastated that their babies are going through it. And so a lot of times their anxiety, they're just like, oh my gosh. And it's like, just give them to me. Give them to me. I mean, I've had so many moms go, you can do it. And I'm like, I don't have any skin in the game, you guys. This is not, I'm like, just give them to me. I can do it. But then we just have to give them slowly. Once we get them settled, we slowly give them back to mom. And as she gets anxious, we teach her how to do that deep breathing. And it's like, we just kind of talk them off the ledge. And you guys will get better and better at it. But our goal truly is to make sure that these families can care for their babies, because we want them to stay together. We're going to talk about adverse childhood experiences and why we want them to stay together later on this afternoon. Because many of you are probably like, huh, really? Truly, we do. As long as it's safe. I want to make sure I'm touching on everything. What do we treat these babies with if we treat them with a medication? We start with morphine here in Arizona. I was just told that at Banner Desert, they have a baby that they tried on methadone. We'll give them clonidine and then phenobarbital. Mostly the most common treatment is morphine. Some studies are showing music therapy. Do I think that could be something in the future for Hushabye? Yep, I do. Aromatherapy, do I think that could be something of Hushabye? I do. We'll probably do some type of aromatherapy in the nurse's station, out in our outpatient site. I think we'll probably do a little of that just because it works. I know people, I used to think, whatever, but it does work. So we'll go a lot of holistic stuff. We know early intervention is key. We know that they're at very high risk. We know that these little ones need follow-up. And that follow-up means for us to have families be consistent and to really follow through with our recommendations, we have to build trust. And that's when they come in to Hushabye. Every person that they meet, they know that they're not going to get treated bad. And then when they're ready to be discharged, we send them to the pediatrician, to the developmental pediatrician, to an ophthalmologist if needed, the newborn intensive care program, that's called something else now, newborn high-risk perinatal program, sorry, AZIP, and then the support groups that we run. We run a support group every day but Sunday at all different times of the day. We know that there are long-term developmental consequences for babies with NAS. The bad thing is we don't have good data on it because these families, nobody's going to admit that their baby was substance exposed because we're going to judge them even if they've been in recovery when their baby gets into kindergarten. Many of these babies right now get placed in the foster care system and they're not with their biological families, so we lose them. What we need is further research. And Julie's going to talk a little bit later about a lot of the stuff that we're doing. Many of the nurses, a lot of you are going to be like, seriously, we're doing what? Why do we have to do this? It's because we need to prove that what we're doing, everyone that's on this call, this is not done anywhere, our inpatient and our outpatient programs. So we are really having to provide, do research to be able to publish our data, to show everyone, in the world that this is how you care for little babies. I think we're going to learn a lot from everybody. We're going to find stuff that doesn't work, that you guys are going to be like, nope, Tara, it doesn't work. I'm not going to be happy to being told I'm not right, but we're going to find stuff that doesn't work, and that's okay. It's just us learning. And I may say, okay, it didn't work, but I'm going to ask for what is another way to get to the same point, because I don't take no for an answer very well. Cheryl, these babies deserve better treatment, and we don't do a great job right now. But with all of your help, my gosh, we'll do such a good job. One
Tara,
other, yes.
Brittany was asking about just partners in the community with like pediatricians and other providers for both babies and families that kind of are in line with our mission. Can you talk just a little bit about those relationships?
Yeah. So Brittany, right now it's kind of a list of providers, mommy recommended providers. Most of us have been in, well, nurses. The nurses that are from Arizona, we have nurses on the east side and west side. And so those pediatricians come from our recommendations. I'm always like, where do you take your kids? I'm like, whoever you take your kids to is probably who we want to send these families to. And then after we send the families to them, if they have a good experience, I'm like, yep, they're on the list. So like right now, Dr. Robin Lax, she's our medical director, but I've sent babies to her and families love her. She's my kid's pediatrician. I love her. But it's like, okay, go to Dr. Lax. But we do have a list and we just keep creating more. Candace, our family coach, has that list of all the different resources that are out there, but we have tons of partners in the community. I hope that answered, Brittany.
Linnea was just saying AZEIP is amazing. I utilize them a lot with my DCS babies when I was a case manager with Jewish Family and Children's Services.
Every baby with that is discharged from Hushabye, we would like to do the AZIP, the Arizona Early Intervention Program referral. But again, you guys, families are not going to follow through with that unless we've developed the trust, because they're going to hear that this is another person in there coming to look at them and they could call DCS on them, instead of realizing that AZIP, what their goal is that Arizona Early Intervention Program. Their goal is when baby goes to kindergarten, this baby has already been enrolled in services to make them be successful in kindergarten. Studies show that if a child has developmental intervention before the age of 6, outcomes are huge, so much better. And so really the only way we're going to know if a baby's behind or not meeting those milestones is being able to have, interaction with them. And if these families don't trust us, then they're not going to. It's not that they don't want it. It's that they don't want to be judged. I mean, I went to a pediatrician who I still think is one of the smartest pediatricians I know, but his office staff sucked so bad. And I just was like, nope, not going. Nope, not, I mean, and he even asked, why do you not come anymore? I'm like, your front staff is the pits. And he was like, what do you mean? I'm like, they're awful. And I just told him that. So if we're sending someone to a family, like we encourage all of our moms prenatally to get involved with home visiting. So healthy families, teachers as parents, nurse family partnerships. We try to get them connected with them because, again, outcomes are better with them. But I've had some moms that go, my person, I don't like them. I mean, I just don't connect. And I'm like, well, let's get you a new person then. We don't all love each other. And that's okay. Many of you are probably like, I don't really care for Tara right now. Not liking it. I get that. We don't all have to get along. Well, okay, we have to get along, but we don't all have to like each other. Okay? You know what I mean? I'm going to stop there. I don't know what to say in that. I'm going down a rabbit hole there. But more or less, really encouraging these families to follow up and for us to refer them to caregivers and providers that are not going to be judged. That, just like you said, Brittany, that are in line with our mission. Is there some teaching that we have to do? Yep. I'm trying to think. Just recently I had, with all the insurance plans have high risk case managers prenatally for moms that have a history of opiate use disorder or substance use disorder. In the one, the one company does not have great insurance. They need a lot of education. So we're trying to do that education because they've just offended my moms. And I'm like, oh my gosh, they just don't know. And I don't think that they're trying to be mean. They just don't understand trauma-informed care. They don't understand opiate use disorder. They don't understand medication-assisted treatment. And we'll talk more about those. It's a lot. I mean, who would know this stuff? So I just want to go now very quickly through Eat, Sleep, and Console, and we're going to go very quickly about it. So Eat, Sleep, and Console is a neat new way of thinking. Oh, can you guys see my screen? Maybe I didn't just hit.
No, your screen share isn't on.
Yep, I was going to say, I don't think I hit share. I just went to it and went, okay. Here we go. Okay, so Eat, Sleep, and Console. Can your baby, this is really our primary way to assess if our little ones need a medication to withdraw. So ESC, Eat, Sleep, Console. Shoot. Sorry, you guys. I am IT challenged. Can they eat an ounce? Can they sleep for an hour? And then can they be consoled within 10 minutes? And if I can't console them, can someone else console them within 10 minutes? And if we can't meet these things, baby might need to be given morphine. Now, we're going to talk a little bit about why this works, but then talk about where there's going to be variations. But all of you that are volunteering, all of the nurses are going to have more of a direct, what are we doing with this? But the volunteers, you all are going to learn and be like, you can tell us and be like, he isn't sleeping. I am having a difficult time. Not that we're not going to be right there. When you guys come and tour Hushabye, the nursing station is right in the middle, and you have rooms all the way around. And so you literally just take a step out of the room and we're right there. It's been shown to decrease length of stays. You're not having to give as much medication, and it's very family centered and family empowering. We're not going to talk about that. Things for eating. We really follow their cues. When we say that, when a mom told me that withdrawal was like having the worst flu and migraine times 100, when you guys have the flu, you don't go eat a turkey dinner. I mean, that you're going to throw up. Babies that are withdrawing, you can't just give them 2, 3, 4 ounces of formula. They're going to eat it because they know that sucking makes it feel better, and they know that eating makes them feel better until it doesn't. Because when they eat too much, they're going to have vomiting and diarrhea. They're going to get a diaper rash from that. And then they're going to want to eat again, suck. They're going to eat too much, and they're going to have vomiting and diarrhea. And it's just a vicious cycle. So eating small amounts, if that's, a half an ounce every hour, okay, that's okay. Is snacking the big thing that we're going to look at? Is, are they gaining weight on that? Initially, babies lose about 10% of their birth weight, and then they start gaining again. But that's what we're really looking at. If they sleep, if they're able to sleep at least for an hour. Can they sleep on your chest? Yep. Can they sleep in mom's arm? They can, as long as mom's awake. They cannot co-bed. This fancy schmancy snoo, you guys will all learn about how to use that. I have a lot to learn still. They're nice, but and then swaddling. We went through the swaddling. The other two that Harvey Karp started with, these 5 S's: swaddling, shushing, swaying or swinging, side lying, and sucking. And then the stay calm and squatting truly is just what I've learned that works. Teaching families, they say that the squatting is a godsend. I still have many families that their babies are still a year or almost over a year, a couple of them, and I'll see them on our Zoom support groups, and they do a different form of squat, but they still are doing it, and their baby still responds to it. It's like, huh, interesting. The biggie, why all of our volunteers, immediate intervention When that baby's pacifier comes out of their mouth, there should be someone there immediately to put it back in. If that mommy's not there or that mom's exhausted and the volunteer is in charge, you're right there. You can hold the baby, but if baby's sleeping in the crib, you're sitting in the rocking chair, just holding the pacifier. I really expect when you walk into the nursery part of Hushabye Nursery, it should be very quiet. And if there is a baby screaming, when I get to that room, there should be one, if not two people working to get that baby settled down. In the hospital, I think that's one of our biggest things. We don't have the hands to get to these little ones right away. Are they going to die because they don't get picked up right away? Nope. In the hospital, on our neonatal intensive care units, are there babies that will die if we don't get to them right away? Yep. So they trump these little ones. That's why Hushabye is so needed. If they're not able to do this, they eat, sleep, and console, they get points. The nurses will go through all of that, but just all of you volunteers, just so you know what we're doing. If they're not able to meet those things, we're all coming together as a team. So the volunteer, the mom, the nurse practitioner, all of us coming through going, okay, what are you seeing? What else can we do to see if we cannot have to give this little one medication? If we all come to the conclusion that, we've done everything, we give a dose and we see what they need and see if we can settle them. We're not going to give them a dose and automatically go, now you're going to get it every 3 hours like we do in the hospital. We're going to give them a dose and see if we can get them through. And we might be able to. If it doesn't work, we give them another dose and see if we can get them through. If it doesn't work, then we'll do every 3 hours. But we're going to see if we can try to get over that hump, because there are many babies that just have a hard time. And a lot of times it's just they have a hard time. Many people are going to hear this in the middle of the night. And I couldn't understand why this is the case. And when you talk to families, they're up all night, usually doing their stuff at night, and they sleep all during the day. And so we do find that need of these babies having the hardest time in the middle of the night. So any of you volunteers that are early birds or late night owls, we would love your help on those times. I know that it's not a good or an whatever. I don't know I can't talk anymore, guys. I'm done. Done. Questions? You know what I was asking.
She's trying to say that it's probably not the highly popular shift. It's not the most highly sought after shift, but is one that has a high need. So if that's you, that would be great.
Yep. We're talking with the nursing schools to see, and the different colleges to see if we can have them do their clinicals at night to help out. So we'll do a lot of education and we'll get bodies. So it'll be a win-win for them and us.
Tara, I have a question about when will we receive these babies? So they're born, say, at Banner Desert or Good Sam or whatever they call that one now. Would they come then directly to Hushabye, or would they go to their NICU?
Right now, the payers want them to not go to the NICU at all. So really having to keep them away from the NICU is what we want. So the families that we're meeting with prenatally go into the hospital. Oh, darn it. I don't have a green binder. I'll show you a green binder later on today. They're going to go in with this green binder that has all of the information. Oh, Shauna's going to get it.
I have one. Here's what it looks like.
Oh, see Haley's. That binder has everything that they've done to show that they have worked so hard. And in that binder, we're going to have a care coordination letter that prenatally will have been sent to the obstetrician, to the pediatrician, to the case manager, to the home visitor, to the medication assisted treatment program, to anyone that these families are interacted with. But then the family will also have probably 10 of those in their binder. So every nurse that they come in contact with, they're going to go, here's my plan. This is what I want. So if you're seeing my baby start to withdraw, just so you know, thank you, Shauna, this is what I want. And when their baby starts to, in the hospital, they do that modified Finnegan, usually in couplet care. As they start going up, hopefully we've told all these people enough that mom really wants to come to Hushabye.
Okay.
And if we're starting to see those scores go up, that they should be connecting with us. The moms that are prenatally with us, oh, believe me, they let me know. I'm going into delivery. I'm 6 centimeters.
Right.
I'm
Okay.
I already know that they're there, but it is going to be that pediatrician that has to write the order for them to come to us. But are the insurance plans on board to pay for us? Yeah, because we're a third of the cost of the NICU.
Okay.
We should have better outcomes, and not just doing babies. I didn't say this, but the mommies will be able to get outpatient behavioral health therapy on site. So
Nice.
they wouldn't have to leave us to get their treatment. Now, if they're if they're taking methadone and they actually still have to go to the clinic every day, we're going to discuss if the methadone clinic's dropping that off to us or if the families are going to get it. Right now, COVID is under control, so the families will go and get it if they need to. COVID has made it that many of these families earn take homes, and we're going to talk about this a little bit later, but they earn the privilege to have their own and they don't have to go every day. But we'll offer, counseling and psychotherapy and all those things that they can get connected to us right away. I'm hoping that we get those babies from the hospitals that the mom truly did use 30 minutes before. She's not been in recovery at all. Many people think she doesn't even care. And maybe she'll say, yeah, send baby to us. And when she comes in, she gets that, oh, okay, maybe I can do it. And she sees in room 3, 4, 5, and 6, all those moms are doing so well. What are you doing? Maybe I could do it. That's what we hope. That's what we hope. But is it going to be tricky for us to get babies to us? Absolutely. Are all the stars going to have to align? Yep, they are. Once we start showing that our outcomes are so good, do I think it's going to go through the community like, yeah, it's going to go quick. And people are going to be like, okay, send them to Hushabye because they do know what they're doing. But it's something new, and it's, us thinking out of the box. And
what about the parents that are there? Is there going to be some sort of a camaraderie between the parents in the,
right.
Because they can help each other.
Yep. Right now, with COVID, they'll be in their rooms, going to the bathroom, us really having to kind of orchestrate everything.
Right.
Hushabye, it very much prior to COVID was very home-like. So we have a family room. We have right at the nurse's station, we have a big island with the families where they would have been able to eat and interact with all of us. Families that have opiate use disorder or substance use disorder isolate. And we need to pull them out and have them not isolate. And so really that's going to be us going into their rooms and really pulling them out of their shell. But the only way we're going to do that is by building relationships. Sorry, I had one other comment to that. Trisha, what did you say? Something about, sorry, I'm going to come back, Trisha. I know there was some other thing. Natalie, do we provide the bottles and nipples for babies? Yes. Will we parents bring their own? They can if they have a specific one, but no. Will masks be required? Yes, right now. Right now, I got to look at the COVID precautions, but I think everybody's wearing them 24/7, even the families. They are, it's the pits, but we are. We have one outbreak, you guys. The community is going to be like, told you couldn't do it. They should never been doing this. Everybody, good hand washing. If you're sick, please don't come to work. Please don't. Please don't. Yeah. Angie, do we lose the babies in the NICU? No, that any baby can come without mom. Baby can come, yeah. Mom would have to sign a transfer, so she would have to, get that. So like Banner Australia right now has a lot of moms at what we call drop-ins. So they drop in, deliver, and then they leave, and you don't see them again. My hope would be that mom comes in that this is probably where we will get in the future, but mom drops in and hopefully someone will go and talk to that mom, the case manager, and say, they have this great program. It's called Hush My Nursery. You really, you know, if they have an opening, you should do this, and then sign the consent, and then baby gets transferred. But it's going to be a work in progress. Again, getting everybody on board, realizing that this is a good thing, that we do know what we're doing. And I had someone dumb this down for me. When you have a stroke, you go to the ICU, and then you go to a stroke step down unit, because it's the Center for Excellence. You have better outcomes. If you have a baby that's substance exposed, has NAS or NAS, you should go to a place that you're going to have better outcomes. That would be Hush My Nursery, a center for excellence. Outcomes better for mom, for baby, for everyone, for the community. I mean, these babies are beyond expensive. Usually $3,200 a night in the NICU for a minimum of 5 days. If not, I mean, 2 weeks, 3 weeks. I believe at Banner Desert, Cheryl, you have one that's 3 months old, I think. Yeah, right now, 3 months, $3,000 a pop. That's a lot. We're a third of the cost. And we're gonna do really good work. Questions?
Tara, I have the floor plan of the facility. Do you want me to pick it up just so people can kind of get a lay of the land?
Yeah, show it.
Okay.
That'd be great.
All right, stand by. Let me see if I can get it to pull up. You guys see this?
Yes.
Okay, so right here in this bottom corner, I guess. Sorry, you guys are in my, let me move you out of the way. Okay, so this door right here on the right-hand side in the middle is our main entrance. So this is gonna face McDowell. When you come in, it's gonna be right at 30th Street in McDowell, but this is the main entrance. This is a secure facility 24/7. So this door is gonna be locked at all times. We are not even going to do a fob entrance on this door. You will have to be buzzed in. So whether it's the security guard, we have 24/7 security. They can buzz you in, or Anita, our office manager, can buzz you in as well. But this is going to be a secure entrance at all times. This actually looks slightly different. We decided to do a little bit of a modified setup here. So this door actually isn't here to the bathroom, right here in the top right corner. It's actually over here on this side. And this is a straight desk that goes straight across, and Anita and our security guard will sit there. Like Tara was saying, the goal is to just make it feel like really residential, guys. We don't want it to feel uber clinical. We want it to feel like home. We want them to walk in and it doesn't feel like sterile and bland. It's just a very calming and welcoming environment. So this is set up more like a home desk situation. And so there's a double desk right here. This is kind of an entryway with a lobby right here in the top right corner. And there is a television up on the wall. And then this is a guest bathroom with a changing table in it. If you come through the front doors, this is actually slightly different also. This seating area is taken out, and now this is all floor to ceiling storage. So this is going to be for our binders, our brochures, any of our, collateral or extra storage that Candace and Shauna and Julie may need, or if Anita for office supplies, things like that. So this is all storage. This room right here in the bottom right corner is our multi-purpose room. So these doors are really pretty, like view doors. They have glass panels in them, so you can see straight through into the room. And this is going to be the room that we're going to do all of our classes. So all of our support groups are going to be in here, musicology, mommy and me yoga, anything that we have that's in a group setting on the outpatient side. Or even if we have families that are admitted on the inpatient side, they can receive outpatient services while they're with us. So if we have a class that we're running, they can go ahead and take that group or that class. And so we will have a nurse or a volunteer or the PCAs keep an eye on Babe while they come up to do that up here in this multi-purpose room. So if you keep going back this hallway right here, this door, I know it's kind of hard to see with my mouse, but hopefully you can see it. This is another secure entrance. So this is the entrance to the nursery. This door is also on a release switch. We will have fob readers. So staff will be able to do a pass through on this door with a fob reader, but it will also remain locked at all times for security purposes. Anita, and we're going to talk about security a little bit later, I think tomorrow, but Anita or the security guard will also be able to buzz you through this door. These offices right here, this is a social work office. So this is going to have 2 desks in here. This room is a consultation room. This third one is a staff break room. And then this is a administration office as well. Eventually, we do have a basement in this building. So eventually all of those administrative spaces will be moving downstairs. We just opted to hold on building out that space just for funding reasons. So eventually all 4 of these will be consult rooms and all of us will move down to the basement. And then back here, it's pretty uniform across the board. There's another bathroom right here. As Tara was saying, these are all the nurseries. So when we're referring to that nurses station, it's going to be this smaller island right here. This is all nursing storage. There's a refrigerator over here and a sink. And then this is a like desk height counter with a transaction height, like standing countertop on the front end for clinical staff to work at. And then all of these rooms around the outside, with the exception of this one in the bottom left corner, are all nurseries. And I can't remember who it was who asked it, but when we're talking about that kind of communal aspect in the community and trying to bring people together and establish those relationships with each other, that was the thought process behind this long island and this room in the bottom left corner. So this is set up just like a residential island would be in your house. So it has a dishwasher, it has microwave, refrigerators, all of those things. And then these are all bar stools so that people can come out, share a meal with each other, you know, and just be able to kind of take a break and establish those relationships with one another. And then this room back here in the bottom left corner is a family room. It's kind of set up just like a small living room, if you will. So there's a little sectional in here, a television. Over here in the right-hand side is some millwork with a coffee bar. So that again, if they just need a break, they need to decompress and kind of just step away for a few moments, we have that space where they can come out and do so. Again, just trying to keep the stimulus in the rooms to a minimum. So we don't have televisions or phones or anything in the rooms. We just want to try to alleviate any of that. And then the rooms are all set up uniform. Against the back wall, there's a captain's bed with some storage drawers underneath. And then there is like sconce lighting on both sides of it that they can pull to kind of adjust however they need to be able to see. There's a rocking chair. There is the snoo, as Tara was talking about before, which is kind of that fancy smart bassinet. And then a changing table with some more storage underneath. So this is a stairwell right here in the middle, and then this is a stairwell over here. Again, we won't really use those. The only thing that's down there right now is our server room for all of our IT stuff, but eventually we have some really cool plans for a build out downstairs. Oh, and then this thing right here in the middle is the patient client bathroom for the inpatient side. And so this has a toilet here, and then this is a shower. And then sinks, obviously. So we'll have the ability for them to be able to shower and everything while they're staying, if they are going to be staying 24/7 with us.
And if we have daddies that are staying 24/7, we'll go around to all the rooms, tell them that if you have to go to the restroom, dad's going to take a shower. So do it now. And then we'll close it just for dad to be able to shower and then go from there.
Yeah. So hopefully that kind of helps you wrap your head around. Again, it'll be easier to understand once you see it in person, but hopefully that kind of helps show you the space.
Question?
Oh, and washer dryer. So sorry, I forgot about this room. This room right here, just on top of the bathroom, if you will. This has a washing machine and a dryer in here, and then some shelving for storage for like diapers, wipes, extra linen, anything that we may need will be in this room right here in the hallway.
Did you?
Cheryl, what were you going to say?
Treatment room. You mentioned something about an
Oh,
emergency.
back here, right here.
That's our NRP. If a baby's sick, Cheryl, We'll
Thank
have
you.
everything resuscitation there, a code cart and everything.
Thank-
Hopefully it just collects dust,
Yes.
but we
Thank
have
you.
everything that we possibly need.
Yeah, that's this room right here above the family room.
It is pretty tiny, so it fits, but we're gonna
It's tight.
be tight. We may be like moving stuff around, but yeah. Anything else? Any questions, you guys? It on that, I think it kind of looks big, but when you get there, it fits. It all fits.
It's homey. It's
compact,
homey.
but it fits. And like I said before, we're open to any questions, recommendations. If you're a decorator, I'll take your thoughts on it.
Did you see the question about swaddles? Will we have swaddlers to wrap them or only
Yep, we
blankets?
sure will. We actually have a company that's donating the swaddlers. But Natalie, if you have another company, we'll take it. But the one company is giving us one to give to every family. So every family will have one. But yeah, if you guys have connections with any of those different groups that are doing those, I know there's a new study that's out there in the Banner system that they're doing weighted blankets or weighted something. You know, we can look at things like that. I'm open to whatever is going to make it better. I know, you know, when I have the flu, I am the worst sick person ever. And I just can't imagine. Well, I've seen babies go through this. It's horrific. That's all I can say.
There was one other question about food for families.
Okay, so we're trying to get a grant to pay for food. But right now it's going to be heat and serve and like granola bars, the continental breakfast for the morning. But COVID really puts a damper in all of this. I mean, so it's got to be, you know, yogurt,
Cereal.
cereal, boxed cereal, and we'll give you your milk and whatever. And then for lunch, we're thinking like Uncrustables or something. We have microwaves that they could use those. And then for dinner, I'm really trying to get, if you guys know anybody, I'm trying to get like every day of the week have some organization bring in dinner. So, you know, if it's Chick-fil-A, they come in Mondays. On Tuesdays, we know we're having pizza. On Wednesdays, we know we're having this. We're a nonprofit. Many of you that are working, you know, I'm not paying you very much. Sorry. That's all I can say. And with the food, COVID wasn't going on when I did my budget. I didn't think it was going to be a biggie of going in and out. And now I kind of want you to be in and never leave. So that's our goal. If we can get donations, and preferably it would be great if I had someone every Monday, every Tuesday. We're asking for at the very most 24 dinners, which if I'm 12 would be a lot. If we really had 12 moms, or if we had 6 families with a mom and dad, I just don't see that we're going to have that need. I would love it if we did have that need. We'll work on grants. Julie's writing grants galore and see what we can do.
Saying about Ronald McDonald, how they have like groups come in and like prepare meals. The only thing with that is we don't have a licensed kitchen. So because we don't have a full kitchen, it just gets really sticky with licensure about us preparing food for people.
Now,
so like
Carrie, your food trailer, that would
Right.
work.
Right.
I'm like, that actually would work. It's just we don't have the license. And you guys, all of this licensure stuff, you would be amazed at what goes into it. Go ahead, Carrie.
I have a full kitchen. I can license it. This was a business venture that me and my husband put together this summer, and then he decided to be an engineer again. So instead of running a food trailer with me, he's back to engineering, and I have a very expensive food trailer that could work as a commercial kitchen sitting in my front yard. So it's something we can talk about, and it's fully legal and licensable. I just need to add a couple things. I put a $2,200 fire suppression system in it, but we can talk about it. Like it's something.
We will talk, Carrie, for sure.
Like I could pull it and we could plug it in and we could have a licensed kitchen where volunteers could cook food for our families. I've got a deep fryer, grill, soft serve ice cream machine. It's ridiculous, but we can talk later. And
Yeah,
I'd be happy to write it off on my taxes. It could, you know what I mean? Like I could just.
and
write it
you
off.
definitely could write it off. Any 501c3. Now I'm going to do a little pitch for that. 501c3. You all have your tax credit. I would love your 400 or 800 bucks, just so you know. I can't make you give it to me, but you get to say where you want it. So we would love donations. As
Food's not a
someone,
problem. Trailer.
Nat's
oh my
Oh,
gosh,
there's
I
a
love
trailer.
it.
Yeah, it's beautiful, and it's like
And
it was
it-
expensive. So
Truly, Carrie, the community might love that. I mean, just to,
people can
it's like-
volunteer and run it and feed our families every day of the week out of it. We can talk because,
Okay.
like I said, it's the world's most expensive play hut for my children right now.
We will talk. Yay. How exciting.
Asking about an area outside for like barbecues to get people outside. There's not a lot of a footprint on the exterior. We really had to be creative about fitting as many parking spots in as possible. So we'll talk more about that tomorrow with the parking, but there's not, I mean, there is a front parking lot with 2 parking spots in it and kind of some open space in between, but there's nowhere with like a table or anything like that outside, at least right now.
I've got tables and chairs galore, part of the business I did. So we can talk. We'll talk. Yep.
That'd be awesome. Thanks, Carrie.
No problem.
Unless there's any really pressing questions, I want to try to keep us on track as much as possible. So let's take it's 11:18. If we can get everyone just to meet back here at 11:30, we will start our presentation on ACEs. So grab a drink, move around, go to the restroom, and we'll see everybody back here in about 12 minutes.
Thanks, Shauna.